And I want to say, first of all, that me and thousands of my colleagues around the country are adamantly supporting healthcare reform. For reasons that are not clear, I don't see that on many of the town hall news clips on CNN and stuff. Thousands and thousands of us are supporting this. Doctors fought hard against Medicare in the mid-'60s, and now we've grown to actually realize it's our largest income, and this may be something similar. The reason I'm supporting it is I want to make sure anybody in this room that needs to could come and see me or any of my colleagues when you become ill, but are not so ill that you need to go to the emergency room or be admitted to the hospital, where we're all paying for it anyway, and where the costs are 10 times what they would be if they come see me in the clinic. My two main concerns are that everybody can be covered, and that there is real significant cost control, because without it, the whole thing will implode, and we'll have to start all over. Cost control, I think, largely is the interface between physician and patient. If you have a headache and I decide to do an MRI, I've spent $1,000. If I decide to give you Tylenol, I've spent 2 cents. And the MRI may or may not be indicated. Sometimes it's about protecting yourself from liability, but mostly it's just trying to do the right thing for your individual patient. And it's so complicated, none of us can know all that in our heads, and we need some guidance from the system to know what the best evidence is, to do the best intervention that is most cost constructive and will provide the best result for our patient. It's called a system, and we have no system right now. Okay, so let me give you some specific examples of where this happens. So if just this week I saw a patient who's in the hospital with osteomyelitis, infection of the bone. The patient had no insurance. Patients with adequate insurance, Medicare or other forms of private insurance, could receive a special kind of IV and get their whole 6 weeks of IV medication at home. Significantly cheaper than being in the hospital. Alternatively, a pill form of medication that's about $80 a day, but could be taken at home. Neither of those are options for this cash-care patient, so he will be in the hospital for 6 entire weeks getting IV advice around the cost for probably $2,000 a day because he has no coverage. Now we're all paying for this patient's coverage already. Okay. So we all pay for it anyway. This would be significantly cheaper if everybody's covered. So the pool of younger, healthier people can put their money in a big pool. My concern is that public option seems a very important way of creating a large system that can then levy costs, leverage costs with drug companies and with providers and everything else. So my two questions would be, can you provide us assurance that another idea, co-ops or whatever, without a public option can create a large enough pool to leverage pharmaceutical costs, et cetera, to actually affect meaningful cost control, number one. If not, and you all are not convinced yourself that it can do that, are you willing and ready to push a public option through the Senate so that the House and Senate bills could reconcile each other, both with public options, so we could do something meaningful? And if it's necessary, would you consider doing that through the process of reconciliation?
I think for many of the reasons that you stated, based on experience, we need a public option. I think I can speak on for Sheldon. We're both going to do our best. Sheldon, in fact, helped design the option that is healthy. We both support it. We're going to try to get it to conference so that we'll talk about the details of the concept here. As far as reconciliation, we still are trying to do comprehensive reform, still reaching out. I don't think anyone's made a decision about reconciliation yet, but I think we are determined to try to get significant healthcare reform through. I know that's what's coming this year, actually. I think the other thing you pointed out, based upon your experience, is the fact that the old saying, an ounce of prevention is worth a pound of cure. I mean, you made it very clear from your own practice where if people just have access to insurance, that they can get the care in a timely way. And you can multiply that not just by individual experience, but for a portion of the Medicare population, the first time they really get comprehensive health care is when they're 65 years old and they qualify for Medicare. Before that, it's hit or miss, that if they don't have the access to your clinic, that's not a smart way to run a program, and that's a costly way to run a program. And the other point you made, which I think is extremely important, we have to get back to fundamentals. The whole principle of insurance, private insurance, is to spread the risk across the broadest population. In healthcare, they don't do that. Their principle is to spread the risk among the healthy, which is to minimize the risk. If we have a system in which everyone is covered, everyone must be covered, those young people, and not so young people, will actually be contributing to the care, and the whole issue of insurance, the whole principle of insurance will be validated. So all the points you made, I think, and I want to emphasize again, they're not based on theory. You're every day helping people, do well. Thank you.
Help us help.
I'm going to stay around for a while, but I know other people have engagements that need to get home. So what I would like to do is to thank everyone for coming out tonight. I particularly want to thank Senator Reid for